anthropology and the clinical practice. So he will deliver his speech on maybe 45 to 50 minutes. And as always, we can follow with question and answer. Dr. Azlan, your time now.
Okay. Thank you. Okay, Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajmain. And Assalamualaikum warahmatullahi wabarakatuh, and very good morning to my respected audience, ibu-ibu, bapa-bapa, profesor-profesor, dan dosen, terutama dan juga students daripada Universitas Pajajaran Bandung, Indonesia. To be more specific, students daripada studi antropologi, Fakultas Ilmu Sosial dan Ilmu Politik Universitas Pajajaran Bandung, Indonesia. Dan khususnya juga terima kasih kepada Dr. Erna Herawati sebagai moderator beberapa siri kuliah yang telah saya berikan di sana. Dan I also like to mengucapkan terima kasih kepada Jawatan Kuasa atau Organizing Committee dan for organizing this Dosen Tamu or Invited Lectures program. Syukran jazilan. So Alhamdulillah, for today's program, I will be delivering a lecture entitled Anthropology and Clinical Practice. And I'm going to share my slide. Hopefully, yeah, let me see how I'm going to share this. Okay, let me see. Boleh kelihatan ya di?
Sudah.
Sudah ya? Okay. Okay, right. So this is the slide. Okay. The title for my lecture today will be on medical anthropology and clinical practice. And the content of my presentation will be introduction, anthropology and clinical practice, integration of anthropologists into the clinical setting, patient's exploratory model. And if we have time, if we have ample time, I can proceed to ACHI model, okay, which I wish to advocate. If we don't have time, so we can stop at number 4. If we have more time, we can move on to ACHI model. And finally, we are going to end up with conclusion. All right, so my introduction today will be, what are the issues? So these are the first, the first slide, issues in questions. So we have difficulties in defining clinical practice for anthropologists. The central issue here, do we have, okay, the issue question, what anthropologists would do in clinical setting? Do we have such options to offer? Or do we employ similar clinical approach as clinicians or physicians used to offer? That means, do anthropologists share common interests or common approaches between us and clinicians and physicians in clinical setting? If not, otherwise, what will be our alternatives as far as clinical settings are concerned? So these are things that we observe when we talk about the anthropology and clinical practice. And we do hope that we do hope to present from this brief lecture some examples of how anthropologists have tried very much to, or attempted to, translate the understandings of anthropology for health professionals so that their services to patients can be more humanistic, holistic, or culture sensitive. This is a difficult task that we're going to bear as anthropologists when we talk about anthropology and clinical practice. And if we look at here, and when we talk about anthropology and clinical practice, the issues are, when we talk about this topic, we are dealing with crisis of relevance. Crisis of relevance, we are talking about whether our presence, our being there in a clinical setting is relevant in the biomedical framework or in the biomedical setting. So that means anthropology and clinical practice, or anthropology and clinical medicine, we do have a long association in the biomedical setting, but not by mutual understanding, but more on mutual incomprehension. So doctors or health practitioners look or have long seen anthropologists as merely the collectors of medical exotica from the non-Western world or from the primitive communities, talking about the primitive practices and primitive beliefs. So we do have a long association when we talk about health issues, but in a different perspective. So for the biomedical health practitioners, they look at us as if we are talking about collecting of medical exotica for the non-Western world. So that would be things that we have so far. And then we also talk about the ethnobotany, so indigenous pharmacopoeias. And in this case, anthropologists will try to explain about some of the benefits of the herbal remedies, some of the what I call this, some plants or any herbs found in the field, particularly for the non-Western community, and the usage of these herbs for certain diseases. And then these ideas or this knowledge will be brought up to the Western community, and to be switching and to try to do more experiments or more experiment to see the usage of these herbal remedies in the context of Western setting. So, and then maybe from these ethnobotanical studies in the Western world, that could be very useful to the Western medicine. And that will be the issues of the crisis of relevance. And the third one that I wish to talk about is ethnography, the use of ethnographies as a method. So that means and this method is used to understand how certain diseases can be related to the ways a particular human group has adapted within its own environment. So the issue here is for number 1, number 2, and number 3. So which areas, I could say, which areas that could be of relevant to our needs when we talk about anthropology and clinical practice. And to explain it further on the issue of ethnography, I wish to show you this simple map about the work of anthropologists at the early stage of anthropologists. If you look at the, let me show this in the presentation mode. If you look at this map, at the early development of anthropology, many anthropologists work around the world, and they travel far away from home. And you can see here scholars like Malinowski, again, to use that you can see down below that. That's somewhere in Australia there. Malinowski, he works. He studied people in somewhere in South Pacific Ocean, among the Trobriand, in the Trobriand Island. So we have Raymond Firth, studied somewhere in the South Pacific Ocean, among the Ethiopia. We had the Margaret Mead traveling far away from the United States and studying about people in Samoa. And we also have down below there William Henry Skinner, study about the Maoris in New Zealand. And we have the Clifford Gates in Indonesia, somewhere in Central Java and Bali. The Raki Brown study about Andaman Islands. We also have the Marvin Harris in India. We have Edmund Leach out there studying about hill tribes in Burma, now Myanmar. We have Arthur Kleinman, a well-known medical anthropologist, study people in China. We also have anthropologists studying about the Aborigines of Japan. We got Ainu studies. We have also Rosado studying about people in Philippines, among the Ilongots, and also Barton in Ifugao, Philippines. We have also somewhere in Africa. You can see by Evans Pritchard among the Noah. We also have Mary Douglas studying about Congo and the Lele of Kasai. Marvin Harris in Mozambique. We have Mayor Fortis in Ghana and Talensi in Ashanti. We have Carpanzano and Galna studying about people in Morocco. And we also see up there somewhere quite close to Canada, United States, studying about Lewis Hydromorgan among the Iroquois. And we have the Boers from Boers Kwakitul in Canada and Hobel and Native Americans. Then France Boers and Baffin Islands, Inuit. You also have Myron Harris again in Pardo in Brazil, and we have Leva Strauss in Brazil. So you can see, you look at this map. So the issue here is, what will be our clinical setting? So for anthropologists, are we talking about artificial setting, the so-called clinic, as used to be adopted by our colleagues in the biomedical setting, the health practitioners, or do we have natural setting, the so-called society? So when we look at anthropology as a discipline, our clinic will be more on society rather than artificial setting, because the approach will be could be a little bit different. But anyway, regardless of whichever setting, whether we are going to have the artificial setting, so-called the clinic, or whether we have the natural setting as our clinic, the so-called society, the central issues in question is the application of anthropological knowledge within the setting. That will be our main concern, our main observation here. That means the most important thing for anthropology or medical anthropology in particular is how we go about applying anthropological knowledge within the setting. Whether we are talking about having clinic in a so-called artificial setting, or whether we are going to have the natural setting as our clinic, the so-called the society itself. So the main issues to observe here, will be the use of ethnography, and also and the other one is clinically applied anthropology. Well, that matter, and I would like to go further on the use of ethnography. So when we talk about the use of ethnography in terms of clinical settings, regardless whether we talk about the artificial setting or the natural setting, so the most important thing is we talk about something to do with contextualization. I could say that to understand society and its cultural context. So under this particular area of interest, so I'm going to talk a little bit on the area of preventive medicine. I'm going to talk about anthropology and primary care. I'm going to talk about medicine as a professional subculture. So what do you mean by number one here, anthropology and preventive medicine? Under this, for anthropology and preventive medicine, we are going to talk about what will be our contributions as far as anthropological knowledge is concerned. Number one, for example, under preventive medicine, we can study. We do have studies. We are good in our study on kinship and marital patterns. That will be our strength in when talk about anthropological study. We can, for example, let's say we do encounter many types of marriages, and one of it is called endogamous marriage. And this endogamous marriage will give us some light to understand about the transmission of inherited recessive genetic disorders, such as thalassemia, such as hemophilia, and tay-Sachs disease. So that means that endogamous marriage seems to be, based on the study, is more inclined for the couple, for the next generation, to not to say a must, but to have this a possibility, it's a probability to have some kind of transmission of inherited recessive genetic disorders. Example given just now is thalassemia, hemophilia, and tay-Sachs disease. That will be one kind of study. The second study under this anthropology preventive medicine, we can also study on migration. We talk about public rituals. We talk about pilgrimage. We talk about residential patterns. Particularly, we can study on the slum areas. And these will help, not just helping anthropologists, will help the health practitioners in the biomedical setting to understand how infectious diseases and the vectors of parasitic diseases can spread throughout the population. And that will be the second area that we can go into. And the third area that we can talk about, we can also study about the cultural consumption and practices related to food. So we talk about and I think this is very much related to nutritional anthropology. We can talk about issues relating to overnutrition, or we can study on undernutrition for certain groups. And this study reveals that people often choose what, how, and when to eat on grounds that are not nutritional but more cultural. So it's not about the nutritional issues here, and more about cultural issues when we talk about food. Good example about this can be you have the newly mother to be when they deliver the baby, and they have to undergo certain kind of restrictions known as postpartum period. Postpartum period. So, and under this postpartum period, you can see many Malay mothers, in particular in Malaysia, maybe I think in Indonesia too, where the mothers need to comply with certain taboos and certain food restriction that could be good for them and that could be not good for them from the biomedical perspective. And sometimes, based on the study, they could suffer anemia and whatever throughout the postpartum period. And then we can also talk about under this point number 3. Point number 4, under this anthropology and preventive medicine, we can also talk about subcultural studies. Subcultural studies like the use of alcohol abuse. We can talk about drug abuse. We can talk about smoking behavior. And then at the same time, we can also, anthropological study can also bring into our understanding about what is normal behavior, what is abnormal behavior. And then from this study, the findings that we have, when we talk about alcohol abuse and drug abuse and smoking behavior, and anthropologists can work together with the health practitioners in the biomedical setting to design or to devise programs, the so-called rehabilitation programs. Because from here, the biomedical health practitioners can talk about things from the biomedical perspective, and anthropologists can bring in why to understand the alcohol abuse and drug abuse, and to bring things together, integrate those findings, and we can have a better module, particularly on the rehab programs. So, and finally, number 5, under this anthropology and preventive medicine, we can also talk about cultural expectations. Cultural expectations can be pathogenic to certain individuals, particularly in the Western world. When we talk about type A personality, we talk about the concept of achievement through property accumulation, through flying colors, through working hard, through size of the car. Okay, so the demand and this kind of measurement will be further reinforced. So these are the values that we learn and commonly observed by the Western community and by the Western culture. So and this type A personality will tell us about is it this type A personality can be classified as a Western culture bound disorder. I don't know. Okay, maybe. Okay, because it could be, because we talk about achievements from material gain. So that means if you gain certain things, you are considered as you achieve. How do we go about understanding these cultural expectations of this? And I say these cultural expectations can be pathogenic to certain individuals. That will be under anthropology and preventive medicine. The second thing we can talk about, when we can use ethnographic methods. We can have ethnographic methods in the case of anthropology and primary care. Under this, we talk about the consultations. We can talk about consultations between doctor and patient in their general practice. You can see here in the case of consultation, there will be a conflict, there will be a clash of medical truth between what they believe to be true by the health practitioners in the biomedical setting and the lay health beliefs, okay, coming from the patients. So as a result, there will be some kind of miscommunication. There will be some kind of, at the end of the day, the issue of non-compliance comes in, because there will be a clash of medical truth. What they believe and what the patients believe are not very much, I could say, is more in conflict. And as a result, sometimes the medical advice given by the doctors and by the clinicians will not be very much in compliance. We're not very much inconsistent with the lay health beliefs. And at this particular juncture, the medical anthropologists in particular can help to broaden the concept of consultation. So that means consultation does not mean what is in the clinic. It's not within the four walls. So the medical anthropologists can help, or not, not to say can facilitate the consultation methods to in a wider perspective. We can even broaden up the concept consultation. That means particularly we can talk about the consultation context in two different approaches. Number one, we talk about internal context. That means you can talk about one's experience, one's educational background, one's belief, one's social and cultural background. Okay, that could be internal context. At the same time, we can also talk about the external context. External context means we can talk about we can bring in the social networks. That means patients, when they go to see the medical doctors, they're not talking about their internal context. They are talking about their external context too. And this external context need to be identified during the consultation. What would be, for example, let's say patients, they have the context with the communities of suffering. Let's say if a patient suffering from diabetes, he's not talking about himself. He or she will have the social network, the communities of suffering. I mean, communities for those who are suffering from diabetes. So these are their networking, and sometimes it can be their self-help groups among the patient. So the advice given from the medical doctors in the clinic is one thing, but we do have the society itself as the clinic. So they have the medical advice coming from others. I mean, from the communities of suffering, and these communities of suffering, not just about the patients and diabetic patient and hypertensive patients alone, but they talk about the three sectors, which I used to say in my lectures. We talk about professional sectors, we talk about folk sectors, we talk about popular sectors. All this comes under the issue of primary care. Okay, but the real side of primary healthcare will be the families. So, and you can see when we talk about primary care, it's not about just the biomedical care. We talk about also the social cultural care, and it derives primarily from the family. So how family members being the main healthcare providers. Okay, that would be the second point under anthropology and family care. And the other thing that I'd like to talk about under this, the use of ethnography, is we talk about medicine as a professional subculture. And this, under this particular point, we are talking about, we need to focus about medical profession in the society. Then we talk about issues about diagnostic categories. We talk about types of treatment used. We talk about types of drugs administered by the doctors. And also we talk about the worldviews of health practitioners. What are the worldviews of health practitioners about certain ill health feelings of people in the community, such as from the psychiatrists, from the surgeons, from what are the medical models that we can talk about when we talk about interrelationship between doctors and patients. All this and the use of how much, how many, and the use of folk concepts and language by the GPs. Do we encounter any words, any folk concepts used by the GPs or by the psychiatrists in understanding the role of the so-called their role as a professional doctors or professional health practitioners in dealing with their patient and whatever. So this is the first point which I mentioned just now, which I talked to you. The main observe here, the use of ethnography. So under this particular one, point number one, we talk about these are the three issues: anthropology and preventive medicine, anthropology and primary care, and medicine as a professional subculture. We talk about how anthropologists, particularly medical anthropology, can contribute substantially in the case of what they call this dealing with patients in the biomedical perspective. And of course, the second point that we talk about is a little bit more specific, clinically applied anthropology. Okay? And here, what we are more concerned is about the collaboration between anthropologists and health practitioners in the health setting. So in this word, we are talking about how we can employ anthropological knowledge to understand health issues in the real clinical setting. Okay, and to do that, we need to have more collaboration between anthropologists and health practitioners in the biomedical perspective. And also, we can also talk about applied anthropological knowledge, and we can also talk about our we would like to encourage medical anthropologists to participate more in clinical activities. As of now, I think what I can figure out, medical anthropologists, we have not done good. We have not done well in terms of participating in clinical activities because in anthropology we do not have a special category, a special approach called clinical approach, as we used to have in the medical setting, like doctors and patient, surgeon, or But in anthropology, we spend more time in the society. So perhaps the other option that we can offer would be to do more, to participate more in clinical activities. But in the process of participating more in clinical activities, we need to be cautioned, and we need to caution ourselves. We are not medical doctors. So the role of anthropologists not to get over involved. To get over involved means we should bear in mind we are not medical doctors. We are not taking patients. That is not our job. So we have to be very careful. When I say to participate more in clinical activities, we need to understand doctors and patients. What are the clinical observation made by the health practitioners? So all these are facts or evidence that we can pick up, but we are not taking patient because we are not treating patient. So the role of anthropologists not to get over involved, to play to play the role as a doctor or as a psychiatrist, or in other words, we play active role rather than the role of detached scientists. We should play an active role, but at the same time, this is the dilemma that we get to face. That means we want to participate in clinical activities more to understand about what is really taking place during the clinical kind of consultation, but we don't want to get involved. That means we try to play an active role, but at the same time, we do not want to play the role of a detached scientist. So if you detach yourself, you do not know much what's happening in the clinical setting. Of course, again, the issue of ethics comes in, the issue of privacy comes in. Of course, this will be need to be taken care seriously by anthropologists and the health practitioners in the medical setting. And under this clinical applied anthropology too, we also needs to inform, as Margaret Mead mentioned. So Margaret Mead actually viewed anthropological research as a clinical skill, emphasizing good listening, sensitivity to nuances, and extracting patterns from data. So in other words, here, as you look at when Margaret Mead said, we anthropology, when we do our anthropological research, indirectly, we do have certain clinical skills. We are good listener. We are sensitive to the surrounding. We are sensitive to the culture, to the cultural values and cultural practices within the environment. At the same time, we are able to extract some data in relation to this particular, based on the topic that we are doing. So I would rather say here, we are looking for medical ethnographic data. So that's more inclined to our specialization, medical ethnographic data. And of course, and that these clinical skills need to be incorporated and when it comes to understanding the health behavior of the patient. In other words, we talk about the need to combine theory and practice. We need to combine, we are not just do things theoretically, but we need to do things in a practical way. So our needs, our issue now here is the need to combine theory and practice. And both anthropologists, to do that, both anthropologists and clinicians should have jointly committed to improving the quality and efficacy of care. By having this joint approach, we hope that we are able to ensure the quality and efficacy of care. And another point I can when I talk about clinical and applied anthropology, we also can talk about these two main issues that could be highlighted in responding to patient care. The issue here would be health practitioners and the issue about patient. So, in the case of issues about health practitioners have been dissatisfied with difficulties in providing care that meets patient needs, and have noticed that many of their difficulties are related to patients' background. So this will be the dilemma faced by the health practitioners, particularly in the biomedical perspective. They know very well that they are not happy with the patient's behavior, particularly in meetings, in meeting what they wish to have. So the health practitioners wanted the patient to comply certain things accordingly within their own protocol, within their own needs. And most of health practitioners, they are not satisfied, and they have difficulties in providing care and particularly meeting patient needs. And most of the needs, most of the difficulties are very much related to patients' cultural background. That would be from the health practitioner's point of view. And from patients' point of view, they have another issues. They talk about patients have not that they are not satisfied with the high cost, with low personal attention. And you can see in the clinical setting, in the biomedical setting, most of the time they have little attention to the patient's the patient's need in particular, and they don't spend much time. In other words, you can see there is a kind of a detached concern between the doctors and the patient. It looks that they are very much concerned about what they are doing, but in reality, the relationship between doctors and patient can be classified as a detached concern. You're concerned, but at the same time you detach. You still retain certain kind of professionalism. So at this particular point, anthropologists can chip in. Medical anthropologists can chip in to facilitate the concern of the health practitioners in medical setting, particularly on the cultural sensitive issues with regard to patient and health. Okay, and then let's move on further, and then we can, and at the same time, I will also talk about the how these medical anthropologists could really facilitate the biomedical kind of issues. Medical anthropology can be offered as pre-clinical courses, okay, as a pre-clinical courses for health as an elective course for health practitioners. This is something I think need to be worked out, okay, particularly in terms of to ensure that the health practitioners do understand about the cultural sensitivity of the community itself. So the needs are to have short courses. It can be about alcoholism, it can be about child abuse, it can be drug abuse, elective for medical students. And the talk and these short courses to be administered by medical anthropologists to share a bit of our concern, to share a bit of our issues pertaining to cultural sensitivity. And I only to quote from the Arthur Kleiman in one of his articles. He said, "We need to show that the knowledge we deploy can be useful to physician and patient in the action context of difficult clinical choice. We need to make ourselves useful in order to make ourselves heard." This is, I think, a good, I could say, a good principle. I say a good statement given by Arthur Kleiman. So anthropologists need to tell, to inform, to deliver the knowledge which can be useful to physician. They're not just physicians, can be useful to patient. And we have to make ourselves useful in order to make ourselves heard. And this requirement, I would say, here is to make use of anthropological knowledge or principle that can be incorporated in clinical practice. And sometimes through these pre-clinical courses, in the name of short courses that could be designed. It can be anything. It can be anything about and can be offered to medical students or to the health practitioners as a training for them. And in other words, I think what is more important for the physicians and the clinicians, they wish to have this anthropological information to be incorporated as a cookbook. That means I think the cookbook here means when you want to cook means when you want to do cooking, you don't have time to read the what do you call this, the benefits of the ingredients. Right? What you want to do is you want to cook something, and you open up the book. It's a kind of manual, so that can be referred by you because you want to cook something. So automatically you just read all the ingredients, and you can prepare your meal as mentioned in the cookbook. So I think physicians and clinicians are more interested to have this anthropological information to be incorporated as a cookbook. So when you have this problem, they have something to refer, a kind of manual, and they just look at it, and that's it. So in that, and this part, I think this is something something extremely lacking by us as anthropologists. As of now, I think as of today, if I'm not mistaken, please correct me if I'm wrong, anthropologists are not able to come out this, could say, anthropology cookbook, okay, for the physicians and for the Christians to refer as their manual. I think you can see most of the medical doctors, if you look at the way they work, they have their own protocol to observe. Okay, let's say when they deal with patient with hypertension, they know what are the steps to do it. So these are the protocols that they have to comply with. When you talk about diabetes, what are the things that they have to look for? So the protocols seems to be universal and to be standard all around the world. Okay, as far as medical doctors are concerned. So that's why you can see there's a standard procedures among the clinicians and physicians when they deal with their patient. So as of now, I think I need to admit here that we have to acknowledge the fact that we don't have our anthropological cookbook that can be referred by our colleagues or our collaborators, the so-called doctors and the clinician. And this brings me to the idea of holism. Okay, I think the idea holistic that we used to say in our anthropological work. And of course, these are the things I could say. Well, I'm so sorry about it's quite lengthy here. We all we have all the words here. Well, I just look at the one highlighted in yellow. So what kinds of skills physicians ought to have? So 3 levels of expertise. Number 1, healing. Number 2, educating. Number 3, planning. These are 3 levels of expertise that I think physicians ought to have when we talk about these issues of when we talk about these pre-clinical courses. And to achieve these 3 levels of expertise, so we can have these 7 questions that interest students that relate directly to the skill discussed above. Okay, what are the 7 questions? So for example, if I can read up here, for example, I say, how are diseases distributed in natural communities and what factors affect the distribution? This is called planning. Number 2, how do people assess the meaning of symptoms and decide what to do when they feel sick? This comes to the idea of healing and educating. And then point number 3, what are the relationship between social stress, social support, and personality on the one hand, and on the onset, cause and outcome of disease processes on the other. This comes under the idea of what we call this planning and educating. Number 4, here we have also, you can see what factors affect a person's compliance to a treatment plan. And this comes under the idea of healing. Number 5, what determines how a person will cope with chronic disease. This comes the idea of healing and educating. Number 6, how effective communication patients achieve and what kind of information should be exchanged with patients in order to provide quality of care. This comes under the healing. And number 7, what is the value of the various treatment approaches not informed by biomedical theory or research? This comes under healing and educating. Okay, so that means so that means these are, I think I could say, the some of the 7 questions that could satisfy I could say, the 3 levels of expertise: the healing, educating, and planning, and of which these skills need to be adopted by the physician. And for that matter, so medical anthropologists and health practitioners in biomedical setting can work together to achieve this kind of issues. All this comes under the pre-clinical clinical curriculum, which I suggested just now. And then then what will be our grand design? Okay, and for that matter, how we go about integrating this biomedical and sociocultural framework, and what will be our mission? Okay, so that means in this case, we are talking about integration of the anthropologists into the clinical setting. So that will be our mission now. That will be our grand design, and how to go about it, how to go, how to bring in, how to integrate, how our staff can be integrated, our knowledge can be integrated. And so this slide talk about integration of the anthropologists into the clinical setting. So number one, for that matter, the anthropologist must recognize that the clinician is working with an individual, and that unique problems must be recognized. That means, as far as we are our concern, we need to identify, we must recognize that clinicians is working with an individual, and there's a unique problems between the doctor and the patient itself. But in the case, I could say it's a micro level approach. So as of now, anthropologists, we tend to go for macro level. We tend to talk about society. Yeah, that is one kind of approach, which we are not denying the fact that anthropologists work in the society, participating in the community. We tend to be we tend to employ emic approach in most of the cases, most of the ethnographic data that we gather in the field. But at the same time, we also need to recognize the work of clinicians, because they work at the micro level between a doctor and a patient in a clinical setting. So we need to identify these unique problems. And of course, we need to get this clinical evidence, which I already mentioned just now about medical ethnography of that particular matter. And once we have this in our picture, then we can go for number 2, management of case. After we make this diagnosis. Okay, after diagnosis has been made, so we can go the details into it. Okay, and this will be our job to facilitate and to help the medical health practitioners. And this brings us to the next point on the patient's exploratory model. Okay, I think in the previous lecture I did mention a bit about the patient's exploratory model, but indeed today I'm going to detail it a bit. And this patient's exploratory model came from the idea advocated by our prominent anthropologists at the climate. Okay, so what do you have under this patient's exploratory model? So when you talk about exploratory model, there are 5 central issues to discuss. We talk about etiology, we talk about onset symptom, we talk about pathophysiology, we talk about cause of illness, the severity, and type of signal, and of course, number 5, treatment. So these are the 5 main, I could say, 5 main issues that need to be written or to be observed when we prepare a patient's exploratory model. So every patient has this 5. So if we can, let's say we talk about patients and doctor in a clinical setting, we can get on with these details, with these 5 important dimensions: the etiology, the onset of symptom, pathophysiology, cause of illness, the severity, and whatever, and the treatment. And this, because why we need to have all this, because exploratory model are responsible for the cultural shaping of clinical reality. So this, by having this expository model for every patient. We can go through the what we call this the EMs, and this EM will help us to understand the cultural shaping of clinical reality or the cultural construction of certain issues. Okay, so there we can see there are many. We can look at the medical evidence that will be construed, not just purely in a medical term, but it will be construed culturally by the patient. So, in other words, EMs help us to understand the patient, how this cultural shaping of clinical reality comes in. And the next point, EM also help us in terms of what? EMs are tied to specific systems of knowledge and values. Systems of knowledge and values, what do you call this? In terms of what? In terms of centered in the different social sectors in the healthcare system. So, in other words, when you talk about healthcare system, you talk about the popular system, you talk about the professional system, you talk about the folk system or folk sectors, and they have their specific knowledge. They have a specific knowledge, specific worldview, specific cosmology, specific values, which to be understood by the medical practitioners, including the doctors or clinicians or including the medical anthropologists. And the EMs construct different clinical realities for the same sickness episode. So you can see maybe the patient suffering from hypertension, maybe the patient suffering from all kinds of ill feeling, the same sickness, but they have a different kind of terminology attached to it, different meanings, and this can be further enhanced. We can further enhance by looking at the patient's EM. So by looking at the patient's EM, we know that patients have a different construct about the sickness, and the construction could be influenced very much or could be governed by their cultural beliefs, by their cultural values, and for the health practitioners, and of course they will be governed by their own biological principles, the so-called scientific arguments, or scientific values or scientific realities. Now, EM also construe sickness as a disease, because when we look at EM, we can see there's a difference between the concept of disease and illness. And number 6, that the EM focuses on actual transaction between patients and families and the practitioners. And EM also can help us to study medical pluralism. Medical pluralism in terms of what? Medical belief, medical choices, medical treatments. At the end of the day, healing is the end point of medical system, regardless whichever system they subscribe to. The most important thing for any patient, they wish their sickness to be, to be addressed accordingly, and at the end of the day, they wanted to search for healing, to search for some kind of to get themselves cured from the disease suffered. Okay, I think all right. So now is almost 1 hour, close 8 minutes to 10. Before I move on, if you have time, we can go to the AHI model. Okay, so in other words, I've covered a bit on the issues of medical anthropology and clinical practice from different angles. So yeah, Dr. Ina, if there are any questions from our students and from anybody, I'm willing to answer.
Terima kasih, Dr. Azlan. Silahkan mahasiswa apabila ada pertanyaan. Tadi Dr. Azlan menjelaskan tentang ruang lingkup dan fokus dalam studi antropologi kesehatan, persinggungan dan perbedaannya dengan teman-teman di ilmu kesehatan ya, baik itu perawat, dokter ataupun yang lain. Menarik sekali. Barangkali di antara Anda ada pertanyaan. Kalau misalnya kita sedang riset ya antropologi kesehatan, kadang-kadang kita juga mengambil riset yang temanya rumah sakit misalnya. Nah, bagaimana misalnya menjaga antara batas ya sebagai antropolog dan juga sebagai peneliti dibandingkan sebagai tenaga kesehatan. Sebab kadang-kadang kita juga tahu ya itu penyakit apa, diobati dengan apa, tapi kita tidak boleh untuk menyeberang batas itu juga menarik. Ayo silakan mahasiswa apabila ada pertanyaan kepada Dr. Azlan. Tolong respon apakah kita harus lanjut atau pertanyaannya disimpan untuk nanti. Tolong respon ya. Halo,
Ya,
apakah kita mau lanjut atau bagaimana?
ya, silakan, terserah kepada mahasiswa atau siapa saja yang ada di sana untuk jika ada persoalan. Kalau tidak ada, saya teruskan untuk yang seterusnya. Oke.
Oke. Mohon respon para mahasiswa. Lanjut atau bagaimana? Halo. Sorry about this, Dr. Azlan.
Tak apa,
Oke,
ini,
Reski sudah
ini,
merespon. Belum ada pertanyaan, jadi masih lanjut. Silakan, Dr. Azlan.
Ini budaya ini kalau kita lihat ini budaya Southeast Asian culture ya, bagi orang Melayu atau orang sama saja.
Sulit untuk bertanya. Baik.
Ya,
mari kita lanjut dulu ya.
Kalau saya di semasa saya di negara Inggris itu, kalau dalam kelas itu selalu yang South Asian student will be mereka kurang aktif ya karena
betul.
Banding dengan orang-orang Inggris ya, mereka ada banyak soal.
Mungkin malu atau bagaimana. But this is characteristic of our culture.
Oke. Kalau gitu saya teruskan. Langsung. After looking at this, when I talk about American anthropology and critical practice, so in a way, as a background, which I already discussed in for different topics. So at the end of the day, what as anthropologists, what are we going to do? How we can do this in a better way, or I say what models that I think that we can figure out. So I come up with this one model, not about medical practice alone, but what kind of anthropologists that we wish to be. So in this case, I propose the model is as an Ahi model. So as a Muslim anthropologist, and Muslim anthropologist, so we have a certain role to play, not just to resolve issues on medical issues, but on all other issues. So medical issues or medical ethnographic issues can be one of the issues. So we can incorporate these medical ethnographic issues in this model. And how this model works. Okay. Now, this Ahi model, which I propose, will have 5 main principles. Okay. This is another kind of observation that I have in mind. Right? So number 1, we as a Khalifa, as his viceroy on earth, Caliph. And point number 2 is about anthropological imagination. Okay. And number 3, we have principle number 3 called Sharia compliance. Okay. And this is also observed. We talk about critical practice or medical ethnography evidence. We do agree, we do acknowledge the issues of Sharia compliance. Okay. And then we talk about noble and righteous deeds. You can say Amal Soleh. And at the same time, number 5, the principles for number 5 for this model will be the concept of ibadah, the concept of spiritual guidance and help. So we do things in the guise of ibadah, not in the guise of material rewards. We are not talking about material gain here. We are talking about do things for the sake of ibadah to be rewarded in the hereafter. I think other religions will have the same principle, but I'm talking about here from the Islamic point of view. So being anthropologist is so to be a medical anthropologist and to participate actively in a critical setting, we should have this in mind, 5 principles in this Ahi model. We need to understand we are his Khalifa, a servant of God, and to come here to do good things for the benefits of man, for the benefits of mankind. And we do have anthropological management concept here, Sharia compliance, and Amal Saleh, noble and righteous deeds, and the spiritual guidance. And this is further strengthened by all the verses for the Quran. And for example, let's say this is the Khalifa for the Surah Al-Baqarah, verse 30. Okay, that O Muhammad, when your Lord said to the angels, I'll make upon the earth a successive authority. They say, will you place upon it one who causes corruption and therein and sheds blood? Okay, from this surah, okay, you can read on your own. when I can share this slide to Dr. Inawati later. We talk about this verse of Quran, talk about our what we call this, our authority as his Khalifa. Okay, we do need to do things for mankind. And then we also talk about anthropological imagination in verse Surah Al-Hujurat 13, that we have created you from male and female and made you peoples and tribes that you may know one another. Okay, they need the most noble of you in the sight of Allah is the most righteous one of you. So that, and indeed Allah is knowing and aware. So this concept advocates the principle which emphasizes on our clear conscience and awareness that we are living in a society of the other. So this verse of the Quran saying that you are not living in your own community, you are not living in your own religion. We need to bear in mind that we are living in a society which is not belong to you alone. We live in a society where we have people of multi-religious faith, multi-cultural beliefs, multi of everything. So I would rather say we have a clear conscience and awareness that we are living in a society of the other. Okay, so we need to understand others too, right? Of course, in addition to our Islamic principles, but we need to understand others too. And point number 3, of course, the Sharia compliance. Okay, in this case, we talk about Surah Al-Kafirun, of which we talk about your religion is your religion, my religion is my religion, right? So you can do your own way, okay? And we are not forcing you. So this is what mentioned in the verse of Quran, Kuliya Kafirun, La Abudu Ma Ta'budun, until the end. So all these believers, I do not worship what you worship, nor are you worshippers of what I worship, nor will be I worshipper of what you worship, nor will be you be worshippers of what I worship. For you is your religion, and for me is my religion. So we respect, even though we talk about Sharia compliance, at the same time we retain certain levels of respect. Okay, and certain respect not to the authority, but to of a different faith. Okay, so you can have your understanding, your beliefs, and what we are going to do here is how we can go about to reconcile our beliefs and your beliefs. Okay, in the context of Sharia compliance. So doesn't mean that we're going to sacrifice certain things and certain fundamentals for the sake of certain things. So we are going to look as what we call it, to reconcile what you believe and our belief, and how can we can go about this kind of reconciliation, and hoping that we can meet the objectives of Sharia compliance. Okay, for mankind, again for mankind. And then for number 4, we talk about all these are our good deeds to be observed, and all this has been revealed in our sacred book Quran in Al Imran and Al Shiqaq, verse 114 and verse 125. Verse 25, we talk about amal saleh and good deeds. Okay, and then we talk about the spiritual guidance, and remember all things that we do must be in the guise of not for material gain. It has to be in the guise of ibadah. So when we do things in ibadah, regardless whether you are from whichever religion, our duty here is to deliver something good for mankind. Okay. All these 5 principles, okay, can be translated into one particular diagram here. Okay, you can see here, if I could say, there will be some, you can see the legends down. KH means the Khalifa, A means anthropological imagination, S stands for Sharia compliance, R stands for noble righteous deeds, I spiritual guidance and health ibadah. So you have Asri there, okay, so, and then you have M for module development, SB for sector base, SB1, SB2, SB3, SB4. It can be of anything. It can be politics, economy, law, culture, whatever, any sectors that we can figure out. And all this, the whole circle, the big circle, comes under social engagement. And we have the community at the top there, and the innermost of the community here will be the family. So all this will be the Akhri model, which I to propose. Perhaps we can have this anthropological and critical practice, and how this how this model can help the anthropologists and clinicians to work together. So for that matter, in the case of module development there, so the module development, we can, we have in mind that we are the Khalifa. We do things in the guise of ibadah, and all the asri comes in, and we prepare the module for mankind. And of course, you look at the module development here. The arrow here is a two-way traffic. You see two-way traffic here. It goes into the family. So we know very well the right site for primary care in our case. Let's say the SB1 here, let's say about health issues. So the most important things about module development here is about preparing the module where the family is the active player. Is the active player in the case of certain things, where the patient suffering from, what are the modules for hypertension, what are the modules for for diabetes, what are the modules for thalassemia, what are the modules for hemophilia, so there are many things we can talk. So all this information will be some kind of, we have to secure this evidence from the clinical setting between the doctor. So we get information from the biomedical perspective. At the same time, we can also bring in the social cultural issues to be part of the module, particularly on the cultural sensitivity issues with regard to the patient suffering from hypertension, diabetes, or whatever that we can figure out. So in other words, we see this so this module prepared, and it will be used to in the society. You can see the arrow up there in the community. So if there are any amendments to it, it comes back, it goes back, this arrow come back, go back to the module for improvement. Okay, so these are, I think if you get a little bit confused for this module for today, it's okay, all right, because it takes some time for you to understand about this module. So what I'm proposed now is this module can also be part of the anthropological contribution in clinical practice. So in other words, we prepare this, hoping we can prepare something, modules about clinical practice, which comply with the 5 principles we have mentioned just now: the Khalifa, the anthropological dimension, the Sharia compliance, the noble Russian states, and the issues of ibadah here. So all this comes into the picture. Okay, and then and all this, I think and this process will be easy. So number 1, we got this theoretical framework, Akhi model, and then part number 2, we have community engagement. So anthropologists will go into the to do fieldwork and data collection, and the outcome, of course, since we are talking about anthropology and clinical practice, we are looking for medical ethnography. We're looking for medical ethnography, and this is something what I think something lacking in the biomedical framework. And our part in the social cultural framework, we are lacking in terms of the biological principles which should commonly employed by biomedical health practitioners. So, right, I think that's about it. I think, and then of course, my conclusion for today will be this Surah Rod was 11 truly God alters not what is in people until they alter themselves. So we can only change ourselves. Allah will not change ourselves unless we ourselves change. Okay, for the sake of whatever. Okay, I think that's it. Any questions? You are most welcome. I think that will be the end of my presentation today for anthropology and clinical practice. Okay, so shukran jazilan. Most welcome for any questions. Okay, I think that's about it. Unless you want to ask anything about the module and so on. Okay, thank you, Dr. Ena Herawati.
Thank you, Dr. Azlan, for the very enlightening lecture today. It's very interesting because you talk about the scope and also boundary of doing medical anthropology research. And we have good questions here from the students. She's asking about the boundary of doing medical anthropology research, whether we have to really involve with the people that we are research, or should we draw a boundary not to involve, or when we have to involve in the kind of research to maintain the bias or to prevent the bias.
Yeah.
Do you have any idea about this?
Okay, so soalannya tentang apa praktik pengobatan ya di tempat orang sebagai orang sakit. Apakah tindakan tersebut sewajar di mana tidak mengambil jarak dengan oh, you're talking about the of course when you talk about bias, you talk about something to do to retain some kind of confidentiality. The issue here is we need to understand. For patients, they do have some kind of we call it term of reference, which they have to refer. For medical doctors in particular, they have term of reference to refer. Patients do have their own term of reference, and they wish their ill feeling or disease they are suffering need to be kept confidential. Okay, the issue here is to what extent our job as a medical anthropologist to chip in. To what extent? I would rather say, in this particular case, we need to first, in all kinds of research, in all kinds of things that we do have certain ethics. We can have medical ethics, we can have research ethics. So in this case, we need, for medical anthropology, where you chip into another boundary, which is not your boundary. So we need to ask permission, So whether the patients and the doctors are willing to share the information with you. If the doctors are willing to share and the patients are not willing to share, still we are not able to get the information. And the only way to get the information is by not knowing the person. But I mean, you get the information, but you say, I'm not interested about the name of the patient. Let's say the patient is Salma. We're not interested about Salma. To ensure some kind of confidentiality, we can inform the health practitioners in the biomedical setting. We just want, you can just name it by numbers. Okay, we have, let's say, we can discuss, we can negotiate. Right? We want to get the facts of the case. We say, okay, for today we have patient 1, patient 2, patient 3, patient 4, patient 5. Okay, so we get all the facts. What we want to do is to understand the facts. So being that we are able to come up with a module that could really facilitate not us, but the patient and the doctors and ourselves as medical anthropologists. Let's say a person, let's say drug abuse, or maybe we talk about alcohol abuse. So how we can go and prepare the module for rehab programs? We need to look at the facts. From the facts we are able to do, and I think Dr. Ina will agree with me. Even though when we did our PhD thesis, if you read my PhD thesis, names are not there. All names are pseudonyms. We are not giving any real names. Even the location of the research, until today, nobody knows where is my research setting, because in my thesis, I give another name, pseudonyms. So if you go to University of Canterbury, University of Canterbury, you can look at my thesis, and you will not be able. Who is Salma, the real Salma, and the name of the location is not given. It's just all the pseudonyms, because to protect the privacy and the confidentiality of the data given. So this is how we can go about talking about getting data from the patient and to avoid bias. And the reasons why we don't want to get this, what I call this, the real name, because by not knowing the person, okay, by knowing the person just by numbers, so we are more objective in terms of analysis. But if you know the person, let's say it happens that you go to the hospital and the person is suffering from hypertension or suffering from cancer, for example, and the person is something that you know. So you might be biased, okay, in terms of your analysis. So when you change the name into numbers, perhaps, or maybe other ways, and it helps you to to retain certain levels of objectivity. Okay, you are impartial in your analysis. Okay, thank you, Dr. Irna.
Thank you, Dr. Azlan. I think I would like to follow the questions about boundary again, and also distance. Is it okay for us as a researcher to play a role as a patient or to act as a patient in our own research?
Oh, yeah. This is
Because
called this
it's
is
very
called
difficult, right?
this is called you do things incognito, right? Incognito dalam penyamaran gitu ya. So let's say you want to get data, you want to be admitted in hospital, and you are the one who are suffering from the disease. But the fact that the facts can never lie, okay? Because when you go to you wish to be admitted in the hospital, and you claim that you are suffering from malaria. My doctor said that you are not suffering from malaria. So in this case, Dr. Ina, if you want to be in hospital, you must be the real patient, right? Okay, that means you are really suffering from a kind of chronic disease. Let's say if the person, let's say the researcher, at the same time he or she is suffering from a chronic disease. Let's say we just name it, let's say cancer. So it's a cancer patient. So of course, you can be your experience can be one of your what you call your medical ethnography, but that then you're going to compare your experience and your experience, your living experience with other cancer patient. That to me is okay, but the problem with our data, our self data will be to what extent we can detach ourselves. Detach ourselves means as a researcher, at the same time as a patient. If we can detach ourselves as a patient and as a researcher for about 80%, I think that will be okay. But if we are not able to detach ourselves, and our process of detach ourselves from anthropologists and patient maybe just 30%, then it would not be it will be not advisable to be the data, because it becomes because you are the one who are suffering from cancer, for example, let's say, and then the patient sharing the moment, you still sometimes you are not sharing data, you are sharing feelings more than the data itself. Then I'm afraid of the levels of objectivity will not be achieved in many ways. So if you ask me personally, I will not include my data as one of the ethnographic data. Okay, because my experience can be a kind of your own narrative. You can write your own narrative as a patient, but not as a data. Yeah, as a narrative to share, yes. Okay, I remember in 1986. Okay, when I went to the Orang Asli settlement. Okay, I did suffer malaria. Okay, because of my involvement with the Orang Asli settlement. So unfortunately, I got malaria. So a friend of mine here, Datuk Yahya Awak, can endorse me. And if you go to the Orang Asli settlement to do research and you got malaria, so according to the Orang Asli department, they said you are endorsed as as a real researcher in Orang Asli because you suffer malaria. Okay, so I really participated in the community until to the extent that I got malaria, but yet I did not use my malaria experience in my data collection. So it will just be my own narrative. That can be a very good experience to share between my narrative and the informants narrative in the field. Okay, it will be good to compare. Okay, okay, thank you, Dr. Irna.
Okay, thank you, Dr. Azlan. I think there are no more questions from the students, but I have one question, maybe close questions. What is the trend in among your students about research in medical anthropology? What kind of topic do they really interested at this moment?
In my session, okay, number one, I have to admit, because of the COVID-19 pandemic, so most of them, I could say, fieldwork could not be done as we used to do. Those days before COVID-19, I used to bring my students to the Orang Asli settlement, and among the Aborigines. So we study about the utilization of health services among the orang asli. So that would be the common topic that I use to have for my students in the field. But since 2018, 2000 onwards, because of the MCO and COVID-19, and until today, we don't have the chance to. I don't have the chance to bring our students to the Orang Asli settlement. And even though we have the chance, the director of the Orang Asli Affairs Department would not give us permission for fear of the COVID-19 pandemic. I think my friend here, Dr. Yaya Awang, our former Director General of Orang Asli, can endorse me. I think because if you look carefully in Malaysia, the COVID-19 cases among the Orang Asli is not that many, okay, compared to others. So it's quite something. It's quite interesting, right? Why the Orang Asli did not really suffer COVID-19 compared to us living in the urban setting. So I think the Director General of Orang Asli Affairs, they will not allow us to go in, okay, to make mencemarkan community Orang Asli. Okay, so I think for of that matter, so since we could not do the field work, so I requested them to study about other issues and other issues coming from the secondary sources, whatever issues, particularly on any health and cultural beliefs about health issues. So the students were coming out. So some students will do the field work. They do among the family members, okay, and they do among the neighbors. Okay, very limited movement, but we hope. I think now Malaysia is quite good now. So most probably in this coming September, I think we are open now. We can go to the field. I think we were informed. I think in September 2022, we can start do the field work. I think I can start doing my medical research in the Orang Asli settlement or in other communities. Okay, and I think the other options I used to do is I ask the students to do the medical concept, the medical terminology for certain diseases according to their culture. Okay, so that means if I got 50 students, so maybe they can pick up 2 or 3 concepts which they have in mind. Let's say, for example, let's say in among us in the biomedical perspective, they got the word fever. Fever is demam. So when my students, they go out there and ask their parents, is there any words related to demam? So yes. So in the Malay, demam is demam fever. There's one kind of demam. And then number 2, there's a kind of fever, demam ketegur, okay, which is not really well mentioned in biomedical perspective. So demam ketegur is a kind of fever which involves spiritual intervention. Okay, and then there's another demam. Okay, demam nak pandai. Okay, it's a kind of fever. It's not really a fever. It's also normally among the younger ones, especially among the babies. Okay, we want for let's say teething. Suddenly you do teething. Okay, sometimes they use say from crawling, walking, talking. So for the babies to go to one stage to another stage, they got a kind of fever. And this among the Malays, they believe is a kind of fever that doesn't need kind of treatment. It's a kind of demam nak pandai. So it's a kind of fever you want to achieve certain things, right? So
we have similar belief about that. Yeah, yeah, we do have.
Indonesia pakai apa itu? Demam nak pandai juga.
We don't have the local names for that, but people believe that children who got a fever, they usually will become smarter.
Yeah.
Like
so,
that. Yeah.
What would be the local term? In Malaysia, we do have a local term, demam nak pandai. Okay.
Ya, kita menyebutnya sakit mau pintar, tambah pintar. Ya. Sama. And usually the parents do not bring them to doctor or to hospital because they believe it will just go away in a few days.
Will go away.
Yeah. But the danger is sometimes they don't realize whether the demam is the dengue or not.
Yes, yeah. So I think that could be assignments that my students used to have to do, but of course, very limited because this COVID-19 issues, a pandemic, in a way, students we don't have much favor to be done because of the limitation that we have. Okay, Dr. Ina, thank you.
Thank you. I think similar with us here in Bandung, that students more interested in the pandemic issue. I have two students working on how people respond and memorizing the pandemic here in Bandung.
Yeah. Okay.
Yeah, it's going to be interesting. It's also looking at how people responding to COVID vaccine, which is quite quite interesting, because here in Indonesia, before, people do not want to be vaccinated. But when the government stated that nobody can enter mall or market if they are not vaccinated, then people become interested, and almost everyone want to be vaccinated at this moment, because otherwise they cannot go everywhere. Traveling is banned for those who are not vaccinated, and they cannot enter a traditional market or maybe supermarket if they don't have the vaccine certificate. So it's interesting, because it's not about vaccine at all, but it's about governmentality, and also how the state implement their rules to their citizens. It's very interesting. You posting a questions, or apa, Rizky mau bertanya atau cuma menanggapi tentang dukun bayi? Rizky, we have one more question actually.
Okay.
Rizky. Halo Rizky.
Ya Bu, menanggapi saja.
Oh, menanggapi saja. Maksudnya gimana ya Rizky? Bercerita tentang apa, kemitraan dukun dan bidan atau gimana?
Iya Bu, jadi tadi yang peran antropologi di dunia medis dan klinik yang itu. Jadi kemarin tuh saya sempat menemukan beberapa artikel yang memang secara dari arah tulisannya itu lebih untuk memberikan kesadaran gitu bagi masyarakat dan bagi tenaga medis gitu, seperti kedokteran dan khususnya itu bidan kayak gitu, tentang pentingnya untuk menjalin kemitraan dengan paraji yang itu Bu. Jadi ada beberapa teknik atau pengobatan yang dimiliki oleh paraji yang sesuai dengan konteks kebudayaan masyarakat, yang memang tidak bisa dipraktikkan secara langsung oleh bidan karena ada beberapa penyebab satu dan lainnya, seperti itu Bu.
Oh, okay. Baik. Ya, Rizky discuss about how to collaborate or to post a partnership between dukun bayi, traditional birth attendants, and also clinician practice, instead of sacrificing one profession over another. Because here in Indonesia we have an issue about the government want to stop the practice of traditional birth attendants a few years ago, but then there is a solution how to build a partnership between TBA and also the village midwife, so the practice can still going on. What about in Malaysia?
I think Malaysia, I think the same goes to Malaysia. As of now, Malaysian government did not issue any sanction for the traditional midwives to practice. The traditional midwives in Malaysia still can go on, can practice as usual. At the same time, they can the mothers, the newly mothers to be, they can have an option to go to modern treatment. At the same time, they can also employ the traditional midwife. I think in Malaysia they use both. I could see all the regardless of their ethnic groups, Chinese, Indian, or Malay. Particularly among the Malays, they go for delivering a child, delivering the baby, they go to the hospital. So they get during pregnancy period until the time of delivering the baby, they go to the hospital. At the same time, they also use traditional midwife. Once they deliver the baby, they give birth, they go back to the kampung, to their own village, and they'll get these traditional midwives to attend to all kinds of treatment, massage, wearing shawls, or is using the hot or heated iron bar to heat the abdomen, or kobatungku. So this still in practice, and the government did not stop, did not prohibit the practices of the traditional midwives for that matter. Yeah.
Okay, thank you. Apakah Pak Junardi ada di Zoom ya? Saya tadi lihat Pak Junardi. Halo Pak Jun.
Ya.
Oh, mungkin sudah leaving. Karena disertasi Pak Junardi tentang kemitra, kalau tidak salah tentang maternal and child health di Indonesia, ya.
Oh, bagus ya.
Ya. Beliau riset di Dago kalau tidak salah tentang dukun bayi atau ya local midwife gitu.
Ya.
Tapi
cuma di Malaysia, Dr. Ena, di Malaysia undang-undang hanya menyatakan kelahiran baby itu mesti di hospital.
Okay. Is it obligatory?
Ya, wajib itu.
By the law?
Wajib. Kalau di rumah dianggap tidak selamat dan harus to be monitored by the government midwives.
Sama.
That is a must.
Ya, tapi di Indonesia pada prakteknya di remote area mereka masih melahirkan di rumah karena secara geografis sangat sulit untuk mencapai puskesmas primary healthcare. Seperti di Eastern Indonesia, mereka sampai membuat semacam shelter ke pulau-pulau kecil untuk ibu-ibu yang mau melahirkan. Jadi 1 bulan sebelum mereka melahirkan, mereka dibawa dengan perahu ke satu pulau yang berfungsi untuk tempat melahirkan, tempat persalinan.
Ya, sama di Malaysia, sama di Malaysia.
Ya, jadi problemnya masih di fasilitas dari healthcare-nya yang belum siap gitu. Oke. Baik, sepertinya waktu sudah habis, Dr. Azlan ya.
Ya, baik. Ya, terima kasih.
Terima kasih sekali atas lecture ya, 5 kali lecture yang luar biasa di kelas kami semester ini, dan kami sangat beruntung ada Dr. Azlan sebagai guest lecture di kami. Semoga semester depan kita bisa bertemu lagi di subjek yang lain.
Ya, boleh. Saya juga mengucapkan terima kasih kepada Dr. Inan dan semua komiti yang menjemput saya untuk kuliah ini. Saya ucapkan terima kasih banyak-banyak. Thank you ya. Alhamdulillah.
Baik, terima kasih Dr. Azlan. Terima kasih juga untuk semua mahasiswa yang dengan tekun mendengarkan kuliah selama 5 kali pertemuan dengan Dr. Azlan ya. Semoga semua yang disampaikan oleh beliau sangat bermanfaat untuk bekal Anda yang akan melakukan riset-riset dalam bidang antropologi kesehatan. Dr. Azlan, apabila tidak keberatan, kami boleh minta PowerPoint, file PowerPoint-nya mungkin di PDF
boleh.
Secure gitu.
Oke, saya hantar kepada Dr. Ena ya, Dr. Ena.
Ya, baik, terima kasih.
Terima kasih.
Kita tutup kuliah hari ini. Terima kasih Dr. Azlan, terima kasih untuk semuanya. Semoga sehat selalu, sampai ketemu lagi next semester.